Hello, I am Dr. Ruchir Mehta. I am a vitreoretina consultant at Mehta Super Speciality Eye Hospital in Jamnagar. We'll be kicking off August by speaking about retinopathy of prematurity. It's a topic that is very close to my heart. It's a subject that is very close to my heart, and something that I am practicing and I am planning to practice for the rest of my career. So, to begin with, let us just understand what the problem is. The problem statement in India is that there are 75 lakh babies who are born with low birth weight, which is less than 2,500 grams, and 35 lakh of them are born preterm, which is their gestational age is less than 37 weeks at birth. So these babies are prone to, or they are in danger of developing this disease, this blinding disease called retinopathy of prematurity. So India is currently suffering from something that is called the third epidemic of ROP. In 1940s, in the Western countries, as the newborn care, neonatal care improved, more and more low birth weight babies started surviving. They were able to help them survive, and they used to give a lot of oxygen, supplement a lot of oxygen in the neonatal phase. And they suddenly found a rise in number of cases of ROP. And because of this, they had a lot of research, and they realized that probably it is the oxygen which is the culprit, and it is causing this high number of blindness in these newborn preterm babies. So they started restricting the amount of oxygen supplied to these babies, and then in 1950s they saw drop in number of ROP cases. Then came the second epidemic in 1970s, where the neonatal care improved to such a great extent in the Western countries that a lot of extremely low birth weight babies, that is babies less than 1,000 grams, started surviving. And again they saw a rise in ROP cases. With improved understanding of the disease process and improved neonatal care, they were able to bring it under check. But now the low income countries, the third world countries like India, where the number of babies born every year is so huge that it is basically the neonatal care is not able to meet with the demands of the number of babies that are being born. And also the neonatal care is not standardized. It is probably not evenly distributed, and that is why we are seeing a peak in ROP cases in third world countries, in low income countries like India, and that is what we call the third epidemic. And as I mentioned before, there are 75 lakh babies being born annually, which is the greatest number in the world in India, and now 35 lakh babies are preterm. So now 45 to 50% of babies born less than 1750 grams develop some form of ROP, and almost 10 to 15% of these babies will go completely blind if not treated in time. In fact, a 2007 government data showed that every 2 hours there are 3 babies who reach threshold for treatment in India, and that is a huge number. And a recent publication in 2017 by Dr. Anand Vinekar and colleagues showed that there are less than 100 ophthalmic surgeons who are involved in ROP screening and treatment in India. So there is a great disparity in the need for ROP specialists and the number of preterm babies who require care. Now, the problem in this process is that there are no symptoms, and the signs that a general pediatrician or even to a certain extent general ophthalmologist can pick up, which is the leukocoria, is usually pretty late for any treatment. So it is very important for the pediatricians and even general ophthalmologists to realize that the ROP screening has to be done according to the National Neonatology Forum guidelines, which is when the babies are born less than 34 weeks of gestation or less than 1750 grams at birth, they have to be screened within 30 days of life. If the babies are smaller, that is, if the babies are less than 28 weeks at birth or less than 1200 grams at birth, then they have to be screened within 2 to 3 weeks of life. Even bigger babies, 34 to 36 weeks gestation or 1750 to 2000 gram babies, they need retinal evaluation within 30 days of life if there are certain factors which are risk factors basically. So that includes multiple blood transfusions because of anemia, even multiple pregnancy, that is twin, triplet. Usually what we have seen in our practice is almost 30 to 40% of the babies that we screen are twins or triplets, and a lot of them are born out of IVF treatment. So usually IVF treatment babies are preterm, and that is multiple pregnancy, and these babies do require screening. Also oxygen therapy more than 7 days, ventilation, hyaline membrane disease, respiratory distress syndrome, all these are risk factors for developing ROP even in bigger babies. By bigger I mean greater than 34 weeks or greater than 1750 grams. So these babies have to be screened properly, even if it means going to the NICU, neonatal intensive care units, and coordinating with the pediatrician or the neonatologist, sensitizing them for the necessity of screening, and then planning a regular screening with them for all the babies that they have. So it is very important to speak to the neonatologists, to speak to the pediatricians. There are certain misconceptions about the disease process. There are other problem that we have experienced in our practice is there is failure on part of certain medical people to update themselves with recent screening guidelines and treatment strategies, and that too creates unwanted and unnecessary complications for the babies and the doctor themselves. What is required, it is also important for the treating doctor to be very it is to the advantage of the surgeon and the patients if the treating ophthalmologist has a retinal camera, fundus camera, neonatal camera to kind of explain the patient's parents, the concerned parents, about the disease process. But even without these instruments, it is very important that the treating ophthalmologist explains the entire problem, the process very clearly to the parents, and is very upfront and honest about the outcome and the requirement for treatment. Because what we have seen in our practice is, even after explaining the situation to the patients, especially in the government setup, it is very difficult to gain their trust. It is very difficult to actually sensitize the parents for the need for treatment, because the baby is so small and they do not see any problem as such as when the treatment is actually required. So the treating doctor has to be very patient and has to be very elaborate about the need for treatment. The gold standard for treatment remains laser, although intravitreal injections have been quite extensively used, and there are new trials, especially the Rainbow trial, which shows intravitreal injections are probably equally effective as compared to laser. But laser remains the gold standard, as I said, and it gives almost 95% good anatomical outcome, and majority of these babies will have best corrected visual acuity of 6/12 or better. Also important is that the treatment, once as a treating doctor you decide to treat a baby, it is important that the treatment is done within the next 2 to 3 days. Especially it has to be done before 39-40 weeks of gestation, because usually ROP the severity of ROP will decrease post 40 weeks of gestation. So repeated follow-ups are very important here, and after treatment, especially after laser treatment, the follow-up should be till around 50 to 55 weeks. Post injection, there have been cases of recurrent disease till 70-72 weeks of birth. So accordingly the follow-up should be planned. Also important to tell the parents is that the babies, the preterm babies also tend to develop refractive errors more than the normal babies. So it is important to follow these babies up very regularly. We usually call our babies 3 to 4 months. Once we know that the retina is developed well, we call them again at 3 to 4 months of age for retinoscopy and visual acuity evaluation with Teller's charts. And then accordingly we follow up the babies and check for functional outcome. So as the neonatal care improves, as the medications improve, as the ability of the pediatricians to help these really small babies survive improves, the disease ROP is also going to increase, and the problem is just going to increase. And it is very important for all of us as ophthalmologists, as pediatricians, as gynecologists, all of us to work together to sensitize ourselves, sensitize our colleagues, sensitize our patients, the parents, and all the concerned people about the disease, and fight it and help save as many babies from this visual blinding disease. Thank you.